Okay. Okay. Good morning, everyone. I'm Daniel Cabrera. I'm one of the co-chairs for the Department of Medicine Diversity Council, along with Dr. Bessie Young. Before I introduce Dr. Fernandez, I just wanted to give a plug and a reminder that the Department of Medicine Diversity Council, with the support of the department, is undergoing right now and rolling out a climate survey that you've received emails about. We're at about 30%, a little lower for our trainees, but I know that we can get higher. So just to remind you that the importance of a climate survey for us to look at what's going on in our department and see where we can make change. So again, climate survey, if you can complete that. It'll also save you getting repeat emails. So there you go on that front. So it's my honor, it really is an honor to introduce Dr. Fernandez. She comes to us from UCSF, and she's really kind of spent her career, I think initially kind of illuminating disparities in our country, and subsequently also just working on ways to dismantle the inequities that are happening in our patients and our populations that we care for. And I had the privilege to be at an event last night, a meet and greet, and I think there was really two themes for me that came up. And that was one that, she came into medicine really as a way to actually invoke social justice for the things that she was seeing in our society. And that's kind of spearheaded just numerous publications and research and NIH grants and HRSA grants. But really when it comes down to it, she shared an anecdote with us that part of that foundation as well is just really that patient that she cares for right in front of her every day in her clinics, and the students and the learners and the junior faculty that she gets to mentor and bridge to combat disparities. So without further ado, Dr. Alicia Fernandez.
Thank you. Thank you so much for inviting me, Dr. Cabrera, Dr. Young, and the other members of the committee, Dr. Morales. I am really honored to be here. And there is a little bit of a sense of calls to new castles. You folks have wonderful researchers and many people who do very important work in health services research that has helped illuminate these issues. But I still hope that this will be useful, if only as a milestone to say, okay, it's been actually now 16 years since the publication of Unequal Treatment, and where are we? So what I wanted to do in the time we have is talk a little bit about what was this publication of this report. What did it mean? Why does it continue to be relevant today? I want to talk a little bit about some of the research and where are we now, there's been voluminous research on the interpersonal aspects of care, what happens between the physician and the patient in the room. Talk a little bit about quality improvement and its potential for ameliorating disparities in care, show you some national data, and finally share very briefly my own views on healthcare disparity and where I think healthcare systems are going now. So with that, I think it's probably reasonable to, it's early in the morning, and I think I've been taught that you need to activate the learners. So let me give you a quiz. It's not actually a quiz. Let me get a sense of the temperature in the room. Would people say, you get three choices. Would people say that healthcare disparities, let's say particularly say black-white health disparities, not healthcare, but health disparities, black-white health disparities, are they getting better, are they getting worse, or are they staying the same? So how many people think they're getting better? How many people think that they're getting worse? How many people think they're staying the same? Great, so there's a lot of variation, and that is excellent because I will be able to show you some of the data. And I also think that we can have a talk, we can have, I hope, a few minutes of discussion about why we may feel that things are getting worse or staying the same. Because the truth of the matter is that things are getting better. If you look at This shows the differences in life expectancy. Well, the y-axis is years. You can see that the difference in life expectancy has come down for both men and for women. Now, these are still enormous differences in life expectancy, but they have come down. Note too that this is CDC data that ends at 2013. So this is not because of the changes in white life expectancy, which unfortunately are going in the wrong direction. One of the very few countries of the world where life expectancy is actually dropping for a segment of the population. But this is prior to that, and things are getting better. So that's one of the take-home lessons. And then just to put this into context, of course, here are the 3 lines of life expectancy, and they show that things are either staying the same or slightly improving. You don't see on this the impact yet on the white population, which has been among lower socioeconomic status whites. For those of you who are surprised that the Hispanic line is the one which shows the largest life expectancy, that is of course driven entirely by foreign-born Latinos, and reflects both reflects a healthy immigrant advantage, as well as what's now called the Hispanic paradox, which is that despite lower socioeconomic status, foreign-born Latinos tend to have better life expectancy. But still, message number 1 is it doesn't feel that way, but things are getting better. All right, so let's turn now to 2003 and the publication of Unequal Treatment, which was a report by the Institute of Medicine. The report had been commissioned by the Congressional Black Caucus, who wanted to know, hey, we're hearing all of these things about discrimination in healthcare. Is it true? Is it not true? What is it? And this report was extraordinarily important. Front page of the New York Times, disturbing new study by the IOM has concluded that even when members of minority groups have the same incomes, insurance coverage, they receive notably poorer care. And the Washington Post, race-based inequities, also the front page, sad fact in more than one facet of American life. History has shown how hard they are to overcome. But this week's report paints a picture that cannot be ignored. This was a game changer. Because it put a stake in the ground by summarizing the research that had gone on today and saying, yes, there is a problem here. There is this issue of healthcare disparities. Of course, there was the inevitable other side. Dr. Sattel is a psychiatrist who went on to write a book called The Healthcare Disparities Myth. And she said, are doctors prejudiced according to the media's coverage? The answer is yes. The truth is far less inflammatory than the press would have us believe. What did the IOM report say? It said that the evidence was overwhelming, that disparities exist even when adjusting for potential confounders, that it mainly was about underuse as opposed to overuse of care. It was mainly about underuse of care in minority population, and that they mattered. This underuse of care contributed to worse outcomes, and these were the issues that they looked at. One of the most important things that came out of the IOM report was this, which has served as the sort of conceptual model for examining healthcare disparities for the last 15, 16 years. They put together this graphic, which shows the quality of healthcare on the y-axis, and they examined populations with equal access to healthcare. The Congressional Black Caucus did not need anyone to tell them that the United States is one of the few developed countries in which a large population of its part of the population does not have access to health care. They knew that. They wanted to know whether, if you have access to health care, is there an issue with the quality of health care you receive? And in this map, they said, yes, there is. There is a part of this difference is made up of clinical appropriateness and need and patient preferences, all of which are completely appropriate. If you need different things or if you want different things, you should get different things. But then they said, and part of this is a disparity. And within the healthcare disparity, they pointed out 2 ways of thinking about it. One was the interpersonal, what happens in the room, which they labeled discrimination, and that was made up of bias, stereotyping, as in I'm presenting a patient with hypertension and diabetes, and the attending says check the lipids because that's a cognitive shortcut, that is important to recognize, and then clinical uncertainty. So this was the interpersonal box, and this box was the operation of the healthcare systems. And this is the main conceptual model that has framed much of research. So what I want to do now is talk first about where are we with research in this box, and then I'll shift and talk about where we are with research in the other box. So the IOM report asks this question: how can well-meaning, highly educated health professionals working in usual circumstances create a pattern of care that appears to be discriminatory? And that's right. That's the essential question. How can this happen? Like, how do we understand this? When looking at it from 20,000 feet, it looks like minority groups are systematically getting less procedures or less appropriate care for similar conditions. But how could that be? Why would that be? And there's been a ton of research that has tried to answer this question. This is probably the most important one. The medical students will surely recognize these images from a New England Journal study. These are all actors, and these are actors. And in this study, all of the actors gave the identical script for chest pain, a fairly persuasive story for angina, and a bunch of internists at the ACP conference were told, come on in, watch these videos. We're doing a study on clinical decision making, and we want to know whether or not you would refer patients to angiography. And what they found was that that among men, be it the younger men or the older men, there was no difference in the referral to angiography. And for women, the older Black woman was referred quite less often for angiography for identical symptoms. This is a laboratory study in the sense that it is clean because we're controlling what the patients said. This study has been duplicated many times. I've counted at least 20 publications. It's been done with cardiology fellows, with medical students, with residents, with cardiologists, and with general internists. The results are always the same. African American women receive less aggressive care, to put it that way, for presentation with the same symptoms. So that was one persuasive study which the IOM had. Since then, there's been an attempt to say, okay, we get that. There's some form of bias there. Are there other ways we can study that? And these are led to a lot of vignette studies where, again, patients were rated. And here in this study, white patients were rated as more likely to have social support, more likely to comply with treatment, and more likely to be very pleasant in fairly identical circumstances. The studies that I have personally found the most interesting are the studies that try to get into the room. I work at San Francisco General Hospital. I take care of a very diverse group of patients, African American patients, Latino patients, Asian patients, immigrants we have 140 languages spoken in our hospital per year. So immigrants from all over. And the question is, what happens in the room when you're taking care of patients? And there's studies that, like this one, these type of studies, which I found very illuminating. And this was a study that where people ran audio tapes, ran tape recorders in the cath lab after angiography. And all they did was try to see what happened. And what they found was that less information was given to African American patients, who also asked fewer questions, and there was less social chatter. And that these three things were highly correlated. And the one that people really, and the fact that questions, if a patient asks more questions, obviously we're going to give them more information. That one's a no-brainer. The thing that this was really interesting was the correlation between the social chatter and the amount of questions and the amount of information. Is that your wife in the waiting room? Should I bring her in? Don't worry, you'll be home in a few hours, just in time to watch the ball game. Whatever it is that people came out of the cath lab to say before they said, we found this, That amount of social information, which has been conceptualized as the amount of social distance between the clinician and the patient, is highly associated with the amount of information that we give people and with people's comfort in asking us questions. Very important point, because it seems that at least it could be actionable. And I know that when I'm uncomfortable with a patient, I retreat to a biomedical space and I'm more biomedical. And this seems to say that it's not just me, it's all of us who do this. The other point, and I should have probably put a separate slide on this and didn't, is that what has been seen in the room, there were many studies that looked at things like speech patterns, pressured speech, non-pressured speech, number of interruptions, and so on. The one that I find the most actionable is that in cross-cultural relationships, including relationships, say, with minority patients and a non-minority clinician, we tend to make less empathic statements, fewer empathic statements, almost as if we don't really hear the patient's distress. I was precepting the other day and watching a resident, excellent resident, work with a patient, and the resident noted that the patient, who was an African-American woman in her 50s, had not kept a referral to a specialist. And he said, "Oh, I see you weren't able to go," very non-judgmentally he said, "I see you weren't able to go to the cardiology appointment." And the patient said, "Yes, I was at a funeral." And he did have the wherewithal to say, "Oh, a funeral." And she said, "Yes, my mother died." And he said, "Well, I'll just reschedule the appointment." Excellent resident. Great missed opportunity to say, and it may be because they're young and they don't know that a mother's death is devastating at any age, or it may be because of something in the social distance between the resident and the patient somehow kept him from responding as most of us would do when faced with that sort of a remark. Does that make sense? So again, these sorts of studies, highly illuminating. But they're non-randomized. Has there ever been a randomized study that then says, well, does a physician's race makes a difference beyond all the observational studies about how fast we speak or how fast we don't speak and so on? And the answer is yes, and the reason that you may not have heard of it, though it came out in the Journal of the New York Times last year, is that it was published in the economics literature. This study was done by economists based at Stanford and at the University of Berkeley. It was a randomized clinical study of 637 African American men recruited from barbershops and other sort of community places in Oakland. And they were surveyed before or after seeing a physician. And then they were randomized to either see an African American male physician or a non-African American male physician. There were about 14 doctors in the sample. And before, they were told it was about preventive care and whether or not they wanted to have their blood pressure checked, their weight checked, their cholesterol checked, and their diabetes checked. And that was before they saw the doctor. And after they saw the doctor, they were surveyed again, and also it was seen whether or not they actually got the test. And it turns out that the men who saw the African American doctor were more likely to actually get the preventive test, and that was particularly true for invasive tests. So for an actual lipid blood work, an actual check of their hemoglobin A1C. And this study obviously needs to be repeated. It would be great if this could be done in other places. But nonetheless, it is the first RCT that I'm aware of where we actually see whether or not there's something in there that leads to a difference in patients' actions. And I find it very interesting. You should also know that the patients liked the physicians equally. There was nothing on the survey. They all liked the doctors. It gave them identical ranks, identical scores on satisfaction and understanding. Yet something in it led to a difference in behavior. In addition to race, This is my own work showing something that I think any of the Spanish speakers or other language speakers here know, which is that language skills definitely matter. And here is a study that we did using Kaiser data from Kaiser Northern California. There's over 3,000 patients here. We looked at Spanish-speaking patients who switched from a doctor that did not speak their language discordant, to one who did speak their language, and we examined all the switches and controlled for differences. And what we found is that when people switch from a doctor who doesn't speak their language to one who does, there's a 14-point 14% more of that population a year later had a controlled hemoglobin A1C. And we also looked at people who were forced to switch because their doctor left the Kaiser system, so these are not voluntary switchers, and we found the same thing. So to me, this was a very compelling intervention, a very compelling study, and suggests that for those of you interested in population health or looking to reduce disparities, should obviously think about assuring language concordance. By the way, this is not true for other elements like cholesterol control. But it is true for complex things like glycemic control. So where are we now? Well, we can say that, back to that interpersonal box, we can say the interpersonal box does matter. There is good evidence of implicit bias. And in fact, we also see that the race of the physician does matter, and that the skills, the background of the physician does matter. And in this way, sometimes I go places and I say, oh, are you doing any work on healthcare disparities? And they tell me all the work they're doing in what we call DEI, diversity, equity, and inclusion, to get more people into the workforce. And that is fantastic, necessary, highly important work, if only as an issue of social justice, as these remains great jobs. And we need more people, and we need more people to do them. It does overlap, as I'm showing, with addressing healthcare disparities, because it is part of what a diverse workforce does seem to be correlated with better clinical outcomes. So in summary, where are we now? Stereotypes and bias contribute. Bias is the norm. There is a lot of focus on implicit bias and diversity training. There have been studies linking implicit bias and MD decision making. So scores of implicit bias and MD decision making. And there's increased knowledge about how we communicate differently with different patients. Do physicians accept this? Sort of. This is out of Boston, so it's not necessarily representative of all of the United States, but most physicians now do believe that quality, say in this case, quality of diabetes care does vary by race, ethnicity, within the US healthcare system, at their own medical center, within their own clinic, and perhaps even among the patients we ourselves see. And this sort of stepped approach, you can see it whenever a group of physicians is surveyed. So what does it mean? Yes, physicians have more or less signed on to the fact that there are healthcare disparities and that they even occur among ourselves. All right, what about the second box? The operation of the US healthcare system. Well, a few major points were established early on. One is that the healthcare system is highly segregated. As you know, healthcare tends to be very local, and US housing patterns were intentionally segregated and have remained highly segregated, though that is improving. And what this shows is that the majority of patients are seen only a relatively small group of physicians treat the majority of minority patients. Boy, that's a complicated sentence. I hope you can understand that. Highly segregated. Not only is it segregated, it appears to be inferior. So here is a survey, again, landmark study, looking at what doctors say. And doctors who provide a lot of care to African American patients are less likely to be board certified, are less likely to say that they have access to quality ancillary services, and are less likely to say that they can always provide standard of care. So it's separate and somewhat unequal. And this has been seen, of course, in many, many, many observational studies, large study looking at MIs. We see, again, the segregation in the healthcare system. And we see this same pattern where hospitals that have treat a larger proportion of African Americans tend to have worse outcomes for MI. So, another quiz just to keep us awake. Are minority patients treated at different institutions with different physicians, or are they treated differently within the same institution? What's the answer? Excellent, both. So we have both things going on, and both are important to address, particularly for academic medical centers like us, where we treat a very diverse group of patients. So how do systems of care, not the doctor-patient relationship, but how do systems of care contribute? Well, systems tend to affect all patients, right? It's for the United States has outstanding acute care and not that great chronic disease care by looking at number of people who are treated appropriately. And everyone there are many people who are unhappy with how well integrated the US healthcare system is, but that of course functions more to the detriment of disadvantaged patients. What research has now shown very clearly is that if you can take a clear system, say for example, date of the abnormal mammogram, and follow it through to date of initiation of treatment for breast cancer, or even better, completion of treatment. And what you see are small differences at each step, from the screening mammogram to the diagnostic mammogram to the biopsy to the initiation of treatment. You see that if you're looking at, say, a population of patients, say white patients compared to Black and Latino patients, you see small differences within the cohorts that end up adding up to a larger difference. And that, in the well-done studies that have been done where you can actually call a start date, these are the sorts of results that we see. But the question then comes, can interventions, be it at the hospital level, at the plan level, or at the state level, ameliorate, reduce these disparities? And the answer is absolutely sometimes. So this is a figure I put together to show what can happen. You can have this here where both populations improved and disparities go away. So in fact, screening mammography, the rate of screening mammography for US Blacks and whites, this is what has happened. That rate has now equalized. Huge achievement. You can have a situation where both populations get better, but a sizable gap remains and the gap doesn't change. Flu shots is a good example of that, where you can have a situation where both populations are getting better, but one is improving faster. Virtually every study of a new technology looks like this, where a more advantaged population incorporates the new technology, the health system incorporates the new technology. And this, where one population stays the same and the other one improves and the gap closes, is actually rare, and really only happens when you have an intervention that very specifically targets that population group, such as an intervention aimed at Spanish-speaking diabetics that doesn't impact English-speaking diabetes. Many of the interventions around literacy are like this. So, classic example, the gap in LDL testing for Medicare patients closed. The gap in LDL control actually widened slightly over that time period. But in general, quality improvement works. What's important to note is that the impact on disparities is highly variable. And the generic programs like, okay, let's make sure everyone gets a flu shot in clinic, are less useful for addressing disparities. Doesn't mean they don't improve the rate of flu shots and that isn't important. It's highly important. But if you actually wanted to improve the rate to also reduce the disparities, you would have to measure that, think about it, and then measure it again to see whether or not the intervention works. So let me show you some of what has happened nationally. Now here we see that this is that the male-female gap really narrowed and has almost closed between men and women in giving patients who arrive with an MI appropriate fibrinolytics. And here we see that the gap by race has also gone from a larger gap to a smaller gap. A huge success story. Why did this happen? Years and years and years of research on every single step of the way, implementation of careful protocols to triage people with a suspected MI, implementation of special situations like calling the cath lab right away, and work protocols. And this has been a huge success story with many lives saved. Perhaps by contrast or not, great improvement, not great, some improvement in admissions with congestive heart failure. And here it is by income, and everyone is improving, including the people with the lowest quartile of income, but they're improving a lot less. And we still have a long ways to go, very difficult. And here, what looks like the same graph is actually a graph by race ethnicity, and here these are African Americans. And again, you can see that the rate of improvement has been lower and is nowhere near the rate of improvement in the other groups. And in case you're still wondering about the relationship between race and class, here are admissions in the US for uncontrolled. This is all ARC data, by the way. This is whites, and we see this pattern where the lowest quartile of income is more likely to be admitted for uncontrolled diabetes than the highest quartile of income. And we see that pattern in every group that we examine. But we also see that among African Americans, the highest quartile income does much worse than the lowest quartile income of whites. And among Latinos, it's about the same. The highest quartile does about as well as the second lowest of whites. So this is very suggestive data that really it's a complicated picture, and that both things matter. And yeah, this tells the same story. In this case, it's Hispanics. This shows receipt of appropriate testing for him and it's in this case it's Hispanics that have the lowest rate of appropriate receipt in people with diabetics. But what this shows is that no one's doing very well at only 30%. All right. So what do we get from that? I think there are now some clear-cut sort of best practices for addressing healthcare disparities. I'm going to go through some of the ones that the NQF, the National Quality Forum, has come up with. And that has to do with the focus on an important condition that actually contributes to important outcomes. So for example, hypertension, which contributes to about half of cardiovascular half of the disparity in cardiovascular mortality. And not every condition is ripe for intervention, as we don't know how to address disparities in that condition without appropriate research. There's been a ton of research in cardiovascular disease. The next recommendation is to recognize that, that interventions can take place in both clinical or non-clinical sites, and that usually most effective interventions are multimodal and multi-level, that they involve a clinician, a targeting clinician, a reorganization of the service and the workflows, usually something that targets patients, and usually something that targets the broader community. Despite this being at year 16 since the publication of Unequal Treatment, most healthcare centers, including UCSF, does not include equity as part of the executive dashboard. So they look at how many patients are in the beds, they look at readmission rates, they look at errors, but they don't actually include equity. It hasn't made it to the level of the executive dashboard. This year, UCSF Health instituted its first ever Health Equity Council that will advise the leadership on how to provide outstanding care to all of our patients. While we collect data, we don't routinely stratify quality improvement data by race, ethnicity, or other markers such as insurance. And then there are other recommendations around things that we can do. And then finally, let me just put this, the incentives are misaligned, as you all know. I get paid the same whether actually I'm at San Francisco General, so the more patients I see, the faster I lose the system money. But my appointment times, you know, the amount of time that I have for a patient or the amount of resource is the same, irrespective of whether the patient needs more or needs less, right? We have a one-size-fits-all way of approaching, for example, chronic disease care, which accounts for so much of the morbidity and mortality. And that is really silly. It's very contrary to what we do in any other disease. We don't say, oh, you have the disease asthma, so let me give you this, this, and this. No, we say, do you have mild asthma? Do you have moderate asthma? Do you have severe asthma? We actually triage and treat patients according to their needs. But from a health services point of view, we adopt a very one-size-fits-all standard of practice. And there are no incentives, be it payment or for most places in promotion criteria or whatever, for addressing equity. This is something that UCSF has, the School of Medicine, put into place around 4 years ago, and now one of the areas on which all faculty are evaluated is contributions to diversity and equity. So can we do better? And the answer is yes. When all of these things are done, things can get remarkably better, not only in the national data I showed you, but in local data. This is data from Kaiser, and what this shows is, this is 2001 and this is 2009. And what this is showing, it's sort of complicated, but you can see that hypertension control improved dramatically in that time period. It went from between 40 to 50 to 80. Now, since 2009, we're in the high 90s. That is an incredible achievement. Now, Kaiser has its own healthcare system. It has an integrated healthcare system. It has advantages that the rest of us perhaps don't work with. But they were able to improve the rate of hypertension control in all their populations and heavily reduce disparities. They haven't completely eliminated disparities in hypertension control, but they reduced it by 70%. Well, it's easy to say that's Kaiser, we can't do it, but we have people who are trying to do this in our own safety net hospitals, and what this shows is, this is since May of 2015, we've gone from the high 70s to the mid 80s in, in pretty much all of our population groups. We're still working very hard to address disparities in African American blood pressure control. But the trend is, it's one of those lines where both populations are getting better and the gap is getting smaller. So in summary, despite the fact that healthcare disparities are still not routinely examined by health systems, there is a lot more knowledge of so-called disparity-sensitive conditions, and a lot more knowledge about how to address them. The knowledge is imperfect, but there is a lot more activation on that, particularly in cardiovascular disease. As you know, as I mentioned, national organizations are still working on mandating examination of the data. So the NQF has had debates on this for a lot, and there has been no will to mandate that data be examined by healthcare settings, but many places led by MGH are voluntarily taking that on. As you also may know, there's a recent initiative to add to the collection of race, ethnicity, and language data to now add the collection of sexual orientation, gender identification, so-called SOGI data. And I'm sure you all are in the midst of trying to comply with those new recommendations, as are we. And that, I think, will also be interesting as it expands some of the things that can be looked at. But it remains to be seen, again, whether we'll just collect the data or whether we will actually examine the data in a hypothesis-driven way for healthcare disparities. So about 16 years later, we can say that healthcare disparities remain ubiquitous. They're not caused by bad people. A point that I think is so elementary that I had never made it. And then when I started speaking on this last year, I could see from people who were less immersed in this work, that they still thought that by calling out the interpersonal component of our care, that we were somehow saying that doctors are racist. Not what we're saying. Not what we're saying at all. We're saying, hey, the way we treat patients leads to differences in outcomes and in patient behavior. And the most important thing is the second box, that addressing the operations of the healthcare system probably requires, not probably, definitely requires rethinking how we deliver care. And thinking that through carefully is a challenge. So here's my views on what causes disparities in healthcare. Bad systems, bad doctors, bad science, and bad history. Bad systems we talked about, the fragmentation of care. Bad doctors is a joke, but we are undertrained in critical thinking. We remain undertrained in communication skills and in a focus on quality of care. Bad science I won't talk about today, but there has been a lot of work done on this, including, but anyone who is my age or older will remember beta blockers don't work in these people don't work in this doesn't work in this, and without thinking about that critically and realizing that only about 50% of patients respond to anything you put them on. So there's a lot of overlap about what doesn't work in whom. And then something that I think is really important is to acknowledge the weight of history, which I think is weighing on all of us, that makes us think this is not a good moment and disparities may be increasing. So I created this slide for myself. I'm from Argentina and didn't grow up in the United States, and did go to college here and did learn some US history. But I realized that I had never sort of put this together, and I take care of a fairly large, quite elderly African-American population. And I tried to figure out something about our patients and made this slide, and I encourage you to make your own slides. In my case, I was realizing that most of my African-American patients were actually born in the south of the United States, and they came first to Oakland and then to San Francisco during World War II, often to work in the Kaiser shipyards. So my patient was born in 1934. And in 1934 was when the Hill-Burton Act, which established so many of the hospitals in this country, was made. And Hill-Burton, in theory, desegregated hospitals, but my patient, but true desegregation didn't happen until the Civil Rights Act and more importantly, the establishment of Medicare in the 60s. So my patients were born into black hospitals or white hospitals with black nurses and black blood and those sorts of ideas, which remain important. And my patient would have been 20 by the time Brown versus Board of Education ended legal segregation in the US schools. As you know, the schools are now more segregated than they were at the time of Brown. But at least addressing that, he would have been past the age of formal education. Grown man, by the time the Civil Rights Act ended the remnants of legal discrimination in this country, and then lived to see so many things. The rise of the Civil Rights Movement, the assassination of MLK and other leaders, was 39 when then President Carter apologized on television for the Tuskegee hearings. And then lived to see in Oakland, San Francisco, the Bay Area, the enormous devastation caused by the HIV epidemic, which many people wrongly thought had been loosened upon both the gay and the and particularly African-American communities. In the 90s, lived through the retrenchment of affirmative action and sort of the pendulum swinging back. And then was 74 years old when the first African-American president was elected. And I cannot tell you what that was like for me, seeing patients in those months afterwards. And I'm sure many of you had those experiences. I had patients come in and said, now, Dr. Fernandez, I can control my diabetes. And I'm like, yeah, what am I, chopped liver? Now you can control your diabetes? Like, what was I doing for the last 10 years? But it was such an incredible moment and one to be celebrated. And then, of course, in this patient's case, he continues to be alive and have seen the pendulum swing back. And the patient I made this for now has multiple myeloma. He's an old man. He is delighted that I'm using this slide. And he says, I've seen a lot in my life. And it's very telling. When he comes into the room and I come into the room, we're coming from very different places, and together we've been able to work. So my view on how to eliminate disparities in healthcare includes better doctors. We all need better training, but we also obviously need different doctors, as I've shown in that intersection on addressing healthcare disparities and DEI work. But most importantly, we need better systems and tailored support and an allocation of healthcare resources based on need. Increasingly, we need to think about, and people are thinking about, I'm sure many of you here are thinking about, interventions that can be channeled through healthcare to address the social determinants of health that influence our patients' outcomes. Many places, and perhaps you as well, have done excellent work with patient navigators, which are evidence-based for overcoming challenges for patients with low literacy or limited English proficiency. Lots of systems, such as Penn, are using community health workers. This is not a new idea. They've been around since before the 70s, but using promotoras de salud, peer counseling models, particularly effective, but I won't show you the data, but particularly effective for Latinos with diabetes. Lots of places are working on transportation with rideshare. The data coming out is not encouraging. Perhaps we're targeting the wrong patients, but it doesn't seem to be working so well to reduce no-shows, but still something that is going on and needs to be looked at more carefully. And a lot of systems are addressing in housing, including Florida, Portland, Denver, people that are trying to invest in housing patients experiencing homeless so as to create stability and better conditions for health. What you've also probably heard about is food. Many places are establishing a so-called pharmacy, F-A-R-M, pharmacy, institutions as diverse as Geisinger and safety net hospitals are working on food, providing fruits and vegetables, healthy food to patients with diabetes or hypertension so that we can write a prescription for food. And nationally, there is a cluster randomized trial going on in food pantries to see whether or not the provision of healthy food will lead to a difference. And then last, I think, is what I would consider our most important role, which is to rethink our role as anchor institutions. We are often one of the very largest employers, if not the largest employer in a town. In San Francisco, UCSF Health is the largest employer. And consequently, how we pay people, how much we pay people matters, how we promote, who we hire, all of these questions are extraordinarily important, and I would argue more important, though they're both important, than handing out food. But paying a living wage and accomplishing those things matter very much. So, World World Tour, the world is actually getting better, but the reason it feels like it doesn't is that the last few years have been very difficult. So with that, thank you.
So unfortunately, we don't have time for questions now because we're doing an award presentation, but a really powerful and persuasive talk. Thank you very much, Dr. Fernandez. If you have questions, come down after the awards presentation, and I'll invite Dr. Pao and eventually Dr. Steinberg. I don't know if both at the same time.
I appreciate everybody attending today's Grand Rounds. To such a wonderful Grand Rounds, one that I know Bud Evans would be very proud of, and to be here to share with us a presentation of the Evans Awards. Just a couple words about Dr. Robert Evans, who the award is named after, and a little bit about what the award is. So the award reads that it's presented every year to one graduate, well, we give sometimes more than one when we found unbelievable students. One graduating medical student and one or more second-year residents recognizes the special qualities of warmth, understanding, compassion, and concern for the needs of others is exemplified by and expressed throughout the life of Dr. Robert Evans, who served as chief of medicine for many years at the Seattle VA Medical Center. Dr. Evans was one of the founding members of the Department of Medicine here at University of Washington, was based at the VA, and was a very, very prominent hematologist. And some of you may recognize the name Evans as in Evans syndrome. Evans syndrome is a syndrome of autoimmune hemolytic anemia with thrombocytopenia, first described by Bud Evans. So he's known for that, but I think what he was most known for in our system was being the type of physician that people would want to go to and would want to seek counsel from, mentorship, because of his incredible warmth in caring for the needs of others. So every year, the Department of Medicine recognizes fourth-year medical students and second-year residents that have the Evans qualities, that is warmth, compassion, care for the needs of others. The Evans Award Committee is as follows: Dr. Lyles, myself, Dr. Redinger, Sheffield, Steinberg, Watanabe, and Whiff. This group gets together and takes recommendations from our faculty and residents on individuals that they think should be considered for the Evans Award. The award was started in 1975 as a memorial award for Dr. Evans, who passed away in an accident while he was still on the faculty and had just stepped down as chief of medicine at the VA, but was continuing a new part of his career, and unfortunately was killed in an accident. And this award was made to memorialize him and to really highlight these really important features. I'm going to go ahead and present the student awards, and then we'll invite Dr. Ken Steinberg, head of the residency program, to present the resident awards. This year we are fortunate to have two student awards, two unbelievable students who just emanate Evans qualities at all times. So let me go ahead and read a few comments for our first awardee. Lindsay demonstrated many strengths during her rotation, though I think the three most appreciated by the team were her thoroughness with respect to her patients' issues, her professional, warm, and respectful demeanor with the team, and above all, her natural skill at connecting with patients and their families, which allowed her to be the great advocate for them. She will be a wonderful doctor. I would like to invite Lindsay Bernstein to come on down. I actually would like to invite Lindsay Bernfeld to come on down. Okay. Our second Evans Award for this year, and it is, the recipient is Cody Gehring, and let me read some comments that I think really fit Cody very well. He is one of those very special students who has both high intellectual competence and the very important trait, emotional intelligence. This particular combination predicts very high success in his ongoing training and certainly in the practice of medicine. The patients that he saw felt that he truly cared, and he is an example of the maxim, patients don't care how much you know until they know how much you care. Cody, come on down. I'd like to turn the podium over to Dr. Steinberg for the resident awards.
We'll give it away. This is just one of my favorite awards to give out every year is the Evans Award. Alice Mao, who's one of the R2s who won the award this year, is unable to be here. So I have a picture of Alice. And like Doug, I'll just read a brief comment from one of the attending physicians who worked with Alice. Alice was an absolute joy to work with. I cried on my last day working with her. She demonstrated amazing clinical intuition, a thirst for learning, and for improving her work as an intern, an out-of-this-world educational attitude, and a superior bedside manner. Truly, she is one of the most interpersonally skilled, kind, and gracious people I have ever met. These strengths certainly reflect her interest in primary care, though she would clearly excel in any specialty of her choosing. Alice Mao. I'll get her plaque. And our second awardee this year, because again, there were just two amazing people who received so many nominations from residents and faculty, is Laura Samples. And I'll read a brief paragraph about Laura. Laura was hands down one of the best senior residents I have ever worked with. Her patient care and bedside manner were exceptional. Her work ethic and attitude never faltered, and her team leadership was inspirational. I have never done so little on a medicine service while ward attending, and honestly made very few medical decisions as Laura had it completely under control. Her team and I benefited from her continuously positive attitude and her frequent post-call morning breakfast making. She clearly loves the work and is a stellar senior resident. Laura Samples.